Should I start? Yes, so we have a 42-year-old man, and he was admitted to the hospital complaining of fever, night sweats, and some weight loss in the past month.
Thank you, Marcella. I'm very excited to discuss this case with Robbie. And I'll be brief here because I think everyone in the audience is expert at interpreting this first aliquot of information. And what I mean by that is when you look for markers of inflammation, fever is the most specific, but the night sweats and weight loss is consistent with inflammation. And Marcella has already given us the tempo of disease being subacute. So we have subacute inflammatory syndrome in a middle-aged individual. And what that should prompt us to consider are infections, but atypical infections, cancers, primarily liquid malignancies. Solids usually don't cause such manifestations, though there's always exceptions to the rule. Autoimmune diseases in any flavor, whether seropositive or seronegative, autoinflammatory disorders, drugs would be something to consider, and endocrinopathies. But to be honest, the endocrinopathy is less likely, drugs less likely, so you're really left with atypical infections, cancers liquid more so than solid, autoimmune diseases, and autoinflammatory diseases. We're going to use the HPI to make more progress because based on the symptoms, these are all non-specific inflammatory symptoms, but based on the symptoms that Marcella shares with us, we will be able to identify what organs might be demonstrating pathology, which will help us prioritize the DDX in each of those categories I mentioned. And we'll do that with the labs too, to see if the kidney's involved. Is the heart involved? Is the liver involved? So it's going to be a fun journey that we're about to take. Mike, back to you, Marcella.
Oh, amazing. So let's go on that journey. So 1 year before this admission, the patient started presenting pain on his lower limbs that was worse during physical activities. Then 5 months later, he started complaining of burning sensation on his knees to his feet. And then the patient reported the worsening of his condition during the last month, presenting low-grade fever, night sweats, dry cough, general weakness to the point that he was restricted to his bed and he could not walk. And he also reported some edema up to his knees and weight loss of 25 kilos in the last 5 months. Do you want me to stop here or continue?
Oh my God, please, Marcella, stop here because this is a bamboozling aliquot. Oh my gosh. And you know, I do think it is terribly unfair that we know just how incredibly savvy you are and how passionate you are about infectious disease and rural health. And it's so hard not to be biased by that information, but the way that you're presenting it is making it a little bit easier not to be biased because the syndrome here is so broad. And I'll just talk about the combination of two things, which is, actually, I'll just talk about one thing, which is the severe pain in the limbs that's worsening with physical activity, and then have a conversation with Prof. Rez about everything else. Because for me, that catches my attention in a very concerning way. Let me tell you why. Anytime somebody has anything that's worsened with activity, it's hard not to invoke the cardiovascular system. And I want you to be very deliberate about not saying cardiac, about saying cardiovascular, because you can easily make the mistake of saying somebody has some symptom with exertion, so it has to be the heart. But remember, the heart is ineffective without the vessels connecting the heart back to the body and back to the heart. So in your mind, say cardiovascular. So pain with exertion, especially in the lower limbs, is very evocative of the possibility of peripheral arterial disease. But you know that that term, just not to be fancy, is just translated into claudication. So the question is this gentleman having claudication? And it's hard not to anchor on that because of its morbidity. But before we commit ourselves to going down a very specific pathway of claudication, let's ask ourselves, is there something under the term pseudo claudication? And the answer is yes. Anyone want to take a crack at that in the chat? What kinds of diseases cause pseudo claudication? Anyone heard of this before? Yes, Simi, absolutely. I don't think we met, Simi. Do you have the ability to unmute and introduce yourself?
Hi. Hello, everyone. My name is Simi Lahori, and I'm a research trainee at Mayo Clinic currently. I do not regularly attend the CP Solvers morning reports, and that's why maybe we never met, but I've been attending it for a few days now, and I'm enjoying the discussions that we are having here. And this has been my favorite topic to differentiate vascular and neurogenic claudication. And that's why I just hit that. Yes.
Welcome, Simi. It's a delight to have you here. And thank you for sharing a little bit about yourself, and really look forward to getting to know you better. Yeah, I think you hit the nail on the head. The term neurogenic claudication is actually very important to entertain. And honestly, as somebody who works primarily with older adults, neurogenic claudication and vascular claudication are the bane of my existence because they're actually very hard to figure out. And neurogenic claudication is mainly caused by critical spinal stenosis. So the question here is, does this patient have vascular issues or does this patient have neurologic issues? And the vascular issues are the most acutely morbid and most likely, but you read the subsequent sentences and it has a prominent neurological flavor. The patient has a burning sensation and has weakness, which we'll talk about in more detail. But it's very easy to hear that and say, oh, this must be pseudo-claudication or neurogenic claudication. Let me tell you to be very, very careful. The reason not to commit to neurogenic claudication despite prominent neurologic symptoms is remember that nerves need vessels to live. And this patient might have evidence of peripheral nervous system involvement as a result of ischemia to the nerves or mononeuritis multiplex. So we have to say this person has either claudication or pseudo-claudication, or claudication is wrong, and when we examine him, we realize his bones hurt, who knows? But don't make the mistake of saying that the neurological symptoms confirm neurogenic claudications. The neurological symptoms may be simply a downstream manifestation of arterial occlusion. And then after we gain confidence on this being arterial, neurogenic, or bony, we'll see on the exam, then we can ask ourselves the key question. Most patients with spinal stenosis or vascular disease are older adults with slowly progressive disease. Why is this young adult with rapidly progressive disease getting this phenotype? And that question will be very important to answer. But there's a lot else here to play around with, including the dry cough and everything else. So I'll pass the mic to Prof. Rez.
I absolutely love that discussion. And Robbie, just to show you something, I have your next RLR case. I'm just going to throw this in the background. I don't want to distract the audience, but that's for you to just think about. You're going to love this.
No, you're such a tease.
All right. I do focus. What I'd like to focus on, I'll be brief here. There's a unique pattern that has emerged in the HPI that should really help you prioritize a differential diagnosis. So we knew from step one that this patient is inflamed. Let me ask you a question. If you have edema, what would you expect the weight to be? Would you expect it to go up or down in someone who's retaining fluid? This combination, exactly, Promise, this combination is quite unique. That is lower extremity edema and weight loss. So the question is, what differential diagnosis does that prompt? So I'm not thinking about any other data point right now, but we will use the other data point to help us make progress in our thinking. So when I see this combination, because we know in general edema usually points to the heart the liver, the kidney, or the thyroid gland. But the most common cause is not any of those. Those are the most common causes in this CPS, right? The most common cause is venous stasis. The most common cause is side effect of medications. When you have that combination, it makes me think about conditions like subacute endocarditis, amyloidosis, sarcoidosis, thyrotoxicosis. Now, these are primarily inflammatory conditions that can leave a signature on the heart and lead to edema, but we have to be open that the inflammatory condition might be affecting an organ like the kidney. So we can't anchor yet, but it's worth noting that on the physical exam, when Marcella presents it, I'm going to be paying close attention to what's happening to this JVP, because if I can frame this patient's presentation as inflammatory heart failure, then a unique DDX comes to surface. I will conclude by saying that we are following likely peripheral neuropathy. We're following possible heart or kidney pathology, all with a background of inflammation. Robbie, anything else that you wanted to add here?
No, I love that. I also just love in terms of like teaching delivery. If you guys are also learning to do that, Prof. Raz opens with a punchline. There's a unique signature here. You're like, ugh. Watch that. That's a really cool teaching strategy that he's bamboozling us with. But
he's just complimenting himself because I learned that from him.
Berry shakes make you compliment yourself, I guess, in some circuitous way. Okay, Marcella, tell us more, please.
Yeah, I love this discussion. Thank you so much. So he reported no chronic conditions or significant past medical history, no medications, drugs, or alcohol, or smoking, no allergies. He lives in the central area of Brazil. He works as a farmer, so he has some exposure to cats, dogs, cows, horses, and other farm animals. No travel outside of Brazil, but he already visited almost all the regions of Brazil, but no recent travel. He lives with his mom and his brother. And should I go to the physical exam, or do you want me to stop here? Okay, let's go to the physical exam. So vital signs, heart rate of 90, blood pressure 100/80, O2 saturation was 95 on room air, no fever at the moment. Physical exam, so general, he was awake, alert, and oriented ×3. Chronic will appearing, he was very thin, and he had some cervical lymphadenopathy. His lungs were clear to auscultation, and his cardiac exam was normal. His abdomen was non-tender, but he had a mild hepatosplenomegaly. His extremities were warm, and he had this low extremity edema. And you could notice some presence of small papules on the posterior thighs, legs, and arms. And neurological exam, so he had some decreased sensation to pain and light touch in bilateral low extremities. He had diffuse weakness. He could not walk. He had to have some help, mildly confined to bed, but normal reflexes and coordination. Cranial nerves exam was normal. And we noticed some inability to fully flex his fingers because of some hand edema. And unfortunately, in the mission, I don't have more details about the neuro exam, but maybe if you want to ask something about the exam, I can try to offer.
Marcella, this is so rich. I don't even know where to begin, but let me ask you this question. Do you by chance have a picture of the rash on your phone? Or if you don't, that's totally fine.
No, I don't have a picture.
And was the rash, was it erythematous papules?
Not really. They were not so erythematous, more like papules, just normal.
Just like little bumps on the back?
Yeah,
Okay.
exactly. And it didn't seem to be inflamed. It was something more chronic.
Okay, very helpful. Thank you so much. So maybe Robbie, the way we can tackle this, I'll leave the lymphadenopathy, the hepatosplenomegaly for you to discuss in the vital signs. I'll just focus on, and I think we both can use the social history and the neurologic exam to comment on, if that's okay. But remember, Robbie and I are doing this together, but in reality, we're using each piece of data to try to advance our thinking. With regard to the patient's social history, the truth is, it's more important to know what you don't know. It's more important to know what you don't know. And what I mean by that, I don't know much about Brazil and all of the risk factors for possible infections or even non-infectious disease entities. So knowing that I don't know that, I'm going to be using websites like the CDC so I don't overlook possible infections. You don't need to know everything in medicine. I mean, you should learn as much as you can because it's fun, but you should know what you don't know so that you have a safeguard mechanism to prevent a diagnostic error. That being said, you don't want to just anchor on epidemiologic risk factors. So you almost have to create two frames, one including the epidemiologic risk factors for infections and one excluding them. With regard to the cats, of course, when we hear cats, we automatically think Bartonella, and with Bartonella, you can certainly get an endocarditis and lymphadenopathy. So that's an organism we have to entertain. With horses, there are certain infections, and Robbie can comment on them, that can present with systemic inflammation. With dogs, usually it's more acute with organisms like capnocytophagia and organisms like Pasteurella, especially if you have a dog bite, but there's rabies associated with dogs as well, but this is not consistent with that. Now, moving on to the neurologic exam. We got from history that this patient was having, this burning sensation, and what the burning sensation really did for Robbie was made him convert that to a peripheral neuropathy. When you're approaching peripheral neuropathy, it's really three buckets to consider. These include mononeuropathy multiplex, which is the least likely in all comers with tingling, and polyneuropathy. All of these can have sensory symptoms, motor symptoms, and or autonomic symptoms. We know that this is not mononeuropathy because it's involving both lower extremities. The way that Marcella is describing this, it seems like it's symmetrical and it's length dependent. So this more likely prioritizes a polyneuropathy over mononeuropathy multiplex, though you're always open to mononeuropathy multiplex mimicking a polyneuropathy, and you're just not catching it at the right time. But right now, I'm prioritizing a polyneuropathy. The next step is to think about the second order differential diagnosis for a polyneuropathy. And what that is a myelopathy. This is very important. Myelopathy can present as a polyneuropathy, but that usually has bowel or bladder symptoms, which this patient did not have. And that usually has hyperreflexia, which this patient does not have. So I'm even more confident that this patient has a polyneuropathy. Then the next step is to ask the question, is it acute or is it chronic? Because if you say acute polyneuropathy, there's only a few causes like Guillain-Barré syndrome, acute intermittent porphyria, and some heavy metal toxicity. This doesn't sound like acute. So we're approaching the chronic bucket. When you approach the chronic bucket, in most comers, this is usually related to diabetes, alcohol, or paraproteinemia in the form of a plasma cell dyscrasia. But this patient is quite young. This patient has no past medical history. Be cautious with that. No past medical history doesn't mean no past medical history. Maybe the patient wasn't in care. Maybe this patient has diabetes that's yet to be unveiled. Maybe this patient has HIV. Maybe this patient has Hep C. And you have to be open to the possibility that this neuropathy is independent of what's causing the inflammation. But we'll incorporate the neuropathy as part of the signature of inflammation. And when you do that, the diagnoses that are prioritized include inflammatory diagnoses like lymphoma, like paraproteinemias associated with some lymphoproliferative diseases that I'll leave for Robbie to discuss, and infections and autoimmune diseases, lupus, sarcoid, Sjogren's. All of these can lead to a chronic inflammatory demyelinating polyneuropathy. The last thing I'll say here is this. One step that you can take further for your approach to polyneuropathy is to categorize it as demyelinating or axonal. This actually really helps. In general, the axonal processes are processes that occur that are length dependent. They follow a natural progression and are usually related to the most common etiologies. It's a very broad DDX. And this exercise I'm doing it's limited. It's limited because a lot of stuff can do both axonal and demyelinating. But if you diagnose someone with demyelinating, then that's a unique DDX that you can display. All right, I'm going to pass the mic to Robbie to incorporate the rest of the data and see where he takes us.
Folks, there's a very unique, I'm kidding. There's nothing unique about this exam. It's really perplexing, and I don't really know what to do with it. But I'll share with you the following observation. There are many situations where patients have systemic inflammation and central nervous system issues. Metastatic cancer to the brain, meningitis with cranial neuropathies, epidural abscess, osteomyelitis. How many diseases can you think of that are so prominently inflammatory that result in a peripheral nervous system localization? Most peripheral neuropathy is bland, non-inflammatory, quiescent from toxins, medications, idiopathic, familial, autoimmune diseases for sure, but autoimmune diseases that aren't typically so hectic, like Sjogren's is the most common autoimmune disease to result in neuropathy. So I just want to put that out there, that a tension has emerged and that there is a patient who seems to have prominent systemic inflammation with neuropathy, who's from Brazil. This should immediately make you think, is this leprosy? Now, that reflex thought is tempered a little bit by the nature of the systemic inflammation. This patient has cervical lymphadenopathy and hepatosplenomegaly. What does that fundamentally mean? It fundamentally means that the patient either has a granulomatous infection or has a liquid tumor. It's that simple. Could it be sarcoidosis? Of course, but the lack of pulmonary involvement makes that a little bit less likely. Could it be a myeloproliferative neoplasm? Yeah, for sure. But again, those patients typically aren't so hectically sick so quickly. Could it be a congenital cause of hepatosplenomegaly and lymphadenopathy like Gaucher? For sure, but that is so exceedingly rare. So when you see the combination of lymphadenopathy and splenomegaly, the question is subacute lymphadenopathy plus splenomegaly. Think about granulomatous infection or cancer. Now, whenever you're thinking infection and cancer, you should shut off the cancer hypothesis and prioritize infection until you've ruled out infection. And so we have to go through all the epidemiology here and entertain disseminated tuberculosis, entertain disseminated brucella, all the granulomatous infections. But which one of those causes neuro disease? All of them. All of them cause neurological disease by virtue of space-occupying lesions in the central nervous system. So if we're really confident that this person has peripheral nervous system involvement, then leprosy becomes a priority. And the question that you may ask is, wait, hold on, leprosy, I thought this was a skin disease. And it's true that most leprosy is what's called tuberculoid leprosy. where there is aggressive skin involvement with minimal neurologic involvement, but there are forms of leprosy that are termed lepromatous leprosy, where the skin involvement is more diffuse. And there are forms of leprosy without any skin involvement called the neuritic form of leprosy. So I think that the base rate of leprosy is exceedingly rare, but maybe not so rare in some parts of the world, and maybe not so rare if the following problem representation is true: a systemic inflammatory disease plus a peripheral neuropathy. Now, again, how could we be wrong? We could be wrong because our localization does not involve the esteemed Aaron Berkowitz. It involves the wisdom of Prof. Rez and the foolhardy of me. So if this becomes central, we haven't made any progress. If this is peripheral, I think we can make a lot of progress with this exam. All right, Marcella, back to you.
Well, what an amazing discussion. Thank you so much. So going to the exams, we have a WBC of 3.6, hemoglobin 6.5, platelets 262,000. We have the ferritin 732, potassium 3.29, calcium 10.6, sodium 137, creatinine 2.2, BUN 29.5. His glucose was 76 and hemoglobin A1C 5.6. AST 45.8, ALT 26, GGT 42, C-reactive protein 5.2, alkaline phosphatase 98, albumin 2.7, TSH and T4 normal, vitamin D3, and ESR 69. He also had a CSF analysis that was normal. His CT abdomen revealed some hepatosplenomegaly, chest, CT chest normal. And do you want me to stop here or more exams? We also have electroneuromyography and nerve ultrasound.
And that's super helpful. Marcella, I'll just summarize the abnormalities because I think there are a lot of them in terms of the lab. So there's leukopenia, anemia, and hypoalbuminemia and elevated inflammatory markers. Did I miss anything that was pertinent labs for you guys that you thought was relevant?
No, it was basically that, and also how remarkable his vitamin D was low, was 3.
Oh, I didn't really catch that. It was low. Vitamin D was how low?
3.
Wow. Okay. All right. I have no approach to low vitamin D, unfortunately, except to be concerned about sun exposure, which may tell you how limited his activities were, but then of course involves the esoteric probability of GI malabsorption and things of that nature, which we don't have a prominent signal of, but maybe something to entertain later on. And I'll just talk about the anemia and leukopenia and then pass the mic to Prof. Rez to reflect on everything else. And I'm a little bit surprised by them. I think that whenever there are 2 cell lines down, it's hard not to worry about the bone marrow being involved. But that concern is tempered by the fact that the platelet count is so robustly high. And so I think that CBC is a little bit hard to interpret. And the question is, will we have any clues on the smear to help us say, is it bone marrow or not? And the bone marrow doesn't help us make progress on our initial tension, which is a granulomatous infection versus a liquid tumor. All the infections can go to the bone marrow and all the liquid tumors can go to the bone marrow. So I think that the CBC here tells us, let's look at the smear. and maybe get an LDH. And if we don't find an obvious cause, to pursue the bone marrow biopsy. The one possibility that comes to mind only after saying all this out loud is to loop the vitamin D back in, is to say, is it deficient because there's no sun exposure? Is it deficient because there's GI issues? Or is it deficient because, especially because the calcium is a little bit elevated, is it deficient because it's being hijacked and being made into 125 hydroxy vitamin D? And that would support the idea of a granulomatous process, which again, could be any infection or a liquid tumor. But if you have that elevated 125 hydroxy vitamin D, that would certainly confirm that suspicion. So I don't think I can make much progress between our list on the labs, but maybe the labs help to reinforce that that is in fact maybe the correct list to have. All right, Prof. Rez, Mike, to you.
I absolutely love that, Robbie. And that vitamin D is so low, 3. I mean, how often have you seen that? Most of us have low vitamin D levels, but that is quite striking. And Marcella, just to be clear here, the cross-sectional imaging didn't show any lymphadenopathy?
No, it was mainly cervical.
Mainly cervical. And you said the EMG nerve conduction studies, what did that show?
Sorry, what?
You said that the patient did he have an EMG study or no?
Yeah, I can talk about that next.
Oh, you're going to talk, okay, you're going to talk about that next? Okay, that's fair enough. I really don't have much more to add to what Robbie mentioned. I think, you know, when you start saying polyneuropathy, organomegaly, you just start wondering about Poems syndrome. And honestly, even the physical exam, Robbie, with the papules and lesions, it made me think about Castleman's disease, multicentric form. But you have to still, like Robbie said, worry primarily about granulomatous diseases. And I completely agree. This patient probably will have a high 125D, and that would be an interesting test to pursue. But I'll just stop there. I'm really curious to see what the EMG studies is so that we can talk about that.
Okay, great, thank you. So EMG showed an asymmetrical sensory and motor axonal neuropathy with focal slowing of conduction velocity and severe impairment of the ulnar nerve in the elbow segment and tibial nerves in the ankle. He also had an ultrasonography of his nerves that show hypertrophic neuropathy of the ulnar, median, left peroneal, and tibial nerves, and some signs of intraneural hyperemia in the left ulnar nerve and some mild thickening of the right peroneal nerve. HIV was negative, syphilis negative, and Hep B and Hep C negative.
All right, awesome. It seems like there's some question marks on the whiteboard, Marcella. What did you say about the conduction velocity?
It was a slowing of conduction velocity and severe impairment of ulnar nerve. I can send in the chat to help. Got
it. I want to show something to the group. Let me see. Are y'all able to see my screen here with the axonal versus demyelinating polyneuropathy?
Yes.
Fantastic. I just want to spend 2 minutes walking you through this. Just really, you know, I know this is a CPS exercise, but it's really important that you understand what's most common, because this is 1 in 100,000 case. We want to know what is the 95% of cases. And the highest yield for a distal symmetric polyneuropathy is A1C, B12, and an SPEP. This is recommended by the Society of Neurology. So remember this, know the common before thinking about the rare. But we have to go beyond common because of the clinical presentation. Like none of these will present like this with inflammation. So it takes us away from the high yield. What this is for axonal versus demyelinating, when we say non-length dependent, that's like if someone has numbness in their hands before numbness in their legs, for example, because the legs are the longest nerves in the body. So when we say length dependent, we talk about numbness starting in the feet. When it hits the middle of the shin, then it can start involving the hands, okay? It's really important. You see here, we say that begins distally in the feet, ascends over time, begins diffusely. Both upper extremity and lower extremity may be involved. Now look at this, demyelinating, decreased velocity. Do y'all see that? While axonal, decreased amplitudes. Does that make sense, everyone? The myelin is the thing that you put around the wire. So if it's not there, you're going to have slow transmission of information. So this is really interesting. So this patient is actually not in a purely demyelinating. So stuff like CIDP and GBS are not likely here. And this stuff, just axonal is not likely. Why? Because Marcella said there's decreased velocity. So that EMG actually is showing features of both axonal and demyelinating. So then when you come here into the axonal and or demyelinating, you really, this is not hereditary based on the inflammatory syndrome. Look, this is where we are. Is it something neoplastic like Castleman's and Poems, which then you put the patient's past medical, everything matches. It could be Castleman. Everything could match with that, but we can't anchor yet. Nothing is looking like an autoimmune disease. The only one to consider here is sarcoid. Then you have these infectious etiologies, which is HIV, leprosy, and maybe after this case, we got to add granulomatous to this process, to granulomatous infections. Based on the EMG nerve conduction study that Marcella shared, there seems to be some thickening of the nerves. So when you say thickening of the nerves, it's just making you think of something that's infiltrating those nerves. But folks, lymphoma can infiltrate the nerves, right? Lymphoma can infiltrate the nerves, and granulomatous infections can infiltrate the nerves. So at this point, we're either dealing with a liquid cancer, like a lymphoproliferative disease, lymphoma and its cousins, Castleman's, or we're dealing with a granulomatous infection, or we're dealing with sarcoidosis. That's as far as I can take it, but I'm sure my brother can take it a step further, and that's where I am. I don't know, Robbie, maybe I'm going to challenge you. Is there any way we can make more progress amongst those buckets of disease with all the other clues we have?
Dear friend, I don't think we can, honestly. I think that what I love about your teaching is just how deliberate you are about slowly walking us through the conclusions that we're drawing and stopping at certainty, and then making the margins of what is now speculation. So purely speculation. The truth is we all speculate all the time based on base rate. We say, okay, I have this person who has these features. What happened to the last 100 people with these features? And so the question is, I think the only way we can make progress is to have pretest probability informed by the base rate. And just so you're all clear on what that means nothing to do with this patient. It just means the last 100 people with this problem representation, what did they have, and what does that help us prioritize? And I would say that the base rate is profoundly impacted by the location of this patient's existence. And I will tell you, if you change Brazil and you put this patient in the United States, the base rate is overwhelmingly malignancy. But if you put this patient in central Brazil, the base rate is overwhelmingly leprosy, I think. And so for me, that doesn't inform what is possible. I think it informs the next step. Now, here, let me make an argument for why the next step would be different in the United States versus Brazil. In the United States, the threshold to do a biopsy in this patient would be much, much, much lower now, because you could do a paraprotein assessment and see if the paraprotein is positive, and or you could do a simple hematological workup non-invasively. In this patient with Brazil, because the base rate of leprosy is so high, I think you have to proceed directly towards a biopsy, because you have no other hope of making this diagnosis. It's a very, very complex diagnosis to make, leprosy, which hopefully we can learn about, if not today, then some other time. So can we make progress based on your argument, Professor? I don't think so. But maybe there's something in retrospect we can. But I think because this patient is in a leprosy endemic area, I think my next step would be to pursue that hypothesis. If this patient were not in a leprosy endemic area, my next steps would be completely different. So that's my thought. Anything to add to that before we learn from Marcella, the excellent poker player?
I just wanted to say, I love the way you said, like, basically you're saying there's contextual clinical reasoning, like the context, the locale. I love that. And then you're taking both frames there.
You made me sound so fancy. I can execute. I want that feedback in my official record. I can execute contextual clinical reasoning. Wow. So good. Marcella, tell us more, please.
Oh, wow, that was amazing. Thank you so much. So can I share my screen? I want to show something. Let me see if I. So the patient, can you see my screen? Okay, so the patient had a bone marrow biopsy. And then we can see some like granulomas, macrophage and giant cells. And we can see some acid-fast bacillus staining forming globi, which is very characteristic of Mycobacteria leprae. Because tuberculosis usually forms some cords, it's different. And then we got the final diagnosis, and also that the bacteria was present in the bone marrow, which is quite rare and quite surprising for us. So the final diagnosis was really lepromatous leprosy. We also had like DNA in the blood, DNA in the skin. The small papules were actually like collection of bacillus forming in the skin. And like I had some information that actually the mother and the brother, they had leprosy and they were being treated in the past year. So that was very important, but I didn't want to say the diagnosis so soon. And also, if you were able to see the patient and you could pay really attention, maybe you had some clues because his skin was really infiltrated. So you could see that his face was different, his ears mainly. And yeah, that's the final diagnosis.
Marcella, it's absolutely amazing. I'll tell you my big knowledge gap. I'm trying to find my knowledge gap with every case, and there's so many other ones, but the current one is to understand a little bit what you were teaching us now about the morphology. So what was it that made you think, oh, this is not TB? What before you did the DNA staining? You said something about the.
Yeah, so usually the formation of the bacilli, they form some groups we call globi. So they are like small groups of bacteria, they're mycobacteria, and TB usually don't form that. It's more characteristic of leprosy. TB has more like that cord factor, so like a small percent, they form like a line and not a small group of bacteria.
Incredible. Marcella, this was a blast. It's such a rare presentation of an incredibly common disease worldwide. This is not a rare disease. It's rare for me. I've never, ever seen leprosy except one case in a morning report of a patient who had traveled from an endemic country. And so I'm humbled. I really appreciate you bringing this case to us and presenting it in such a way that really was for such a rich discussion. I had a great time. Thank you. Prof. Rez, thoughts?
Well, I want to echo Robbie and express my gratitude to Marcella for bringing this case and presenting it in the way she did. And Robbie, I'm just so impressed by you, for someone who doesn't practice in Brazil, not to try to embarrass you here, that you saw these constellations and it prompted you to think of leprosy pretty early on. And the truth is, this case could have been, a lymphoma. It could have been another entity. But just to think of that possibility and then try to match it up is really, really helpful. And it really guided what you would do next. And for those of you who are not familiar with leprosy, if you saw when we had the social history that the patient was from Brazil, it's just keeping your mind open to infections that you don't commonly encounter. That is more important than striving to learn everything. The other thing I want to say is there was a really great question in the chat by Ilya Mirzai. Hopefully I'm pronouncing your name correctly, my friend. And that was the question, does lymphoma usually manifest with the leukocytosis? The truth is, lymphoma is one of the trickiest, I think, cancers that you'll ever encounter. It certainly can cause a leukocytosis, and it makes sense because we're saying lymphoma, lymphoproliferative disease. However, it can also cause a leukopenia because remember, you can get infiltration of that bone marrow. In my and Robbie's experiences doing these CPSs, oftentimes what we see is either a normal or slightly low white count, but often we see a lymphocytosis that ends up being our clue. And when you do the smear, you have these abnormal lymphocytes and that push you towards that diagnosis of lymphoma. Very difficult way. It can even present with a normal platelet count. So very humbling diagnosis. Thank you, Marcella. I'm going to pass the mic to the great Rafa Medina. Look at him shake his head saying no.
It's actually Medina, and I'm not great. No, just kidding. Okay, so thank you, Marcella. Marcella is such a good friend, and to see her evolving clinical reasoning, such a joy to watch. Thank you for coming, friend. So I'm gonna give you a little bit of the teaching points. So we started this case with fever, weight loss, and night sweats, all markers of inflammation. Prof. Rez reminded to think about infection, malignancy, primary liquid malignancies, autoimmune drugs, and endocrinopathies. And then we saw on the physical exam of this patient edema. Edema, you could think about the liver, see if there's any jaundice. Most commonly cause would be venous stasis, medication side effects like calcium channel blockers, the kidney, thyroid disease, cardiac causes. For example, if there's heart failure, you could check for crackles or hepatomegaly. Pain in the limbs worsening with physical activity. Rabbit remind us to think about the cardiovascular system, not limit yourself to cardiac causes. Example would be peripheral artery disease in the form of claudication, but cardiac cause would be things like coarctation of the aorta. And we don't have to forget neurological causes as well in the form of pseudo claudication. For example, in the setting of critical spinal stenosis, a clue would be burning pain. However, sometimes you have a vascular cause leading to a neurogenic cause in the setting of, for example, mononeuritis multiplex, where you have a vasculitis leading to a neurological complication. And then we saw that this patient had a polyneuropathy. We should prioritize polyneuropathy here because you could see like the 3 S's, like sensory predominant, symmetric, and slowly progressive. 3 high diagnostic should come in mind, hemoglobin A1C, B12, but also SPAP. When you think about polyneuropathy, think about 2 buckets. Axonal cause, length dependent, a natural progression. It affects much more the legs and the arms, and generally caused by 3 etiologies in the form of toxins, metabolics, or medications. But the other bucket for polyneuropathy is demyelinating disease like GBS, CIDP, and there's myelin everywhere. So, for example, I once presented a case to Aaron, and it was neuropathy starting in the hands. So he was like, oh, this is probably demyelinating, because if it was like axonal, you would expect the legs to be affected first. But you also have to exclude myelopathy. There were no bowel and bladder or reflex disorders in this case, so we excluded that. And there are this spiral that actually lead to the final diagnosis that, remember that lymphoma and granulomatous disease in the form of leprosy in this case can invade the nerves and lead to polyneuropathy. So thank you, everyone. Hope everyone have a good time.
I just want to say absolutely superb job, Rafa. It's amazing to see the growth of the CP Solvers team members. And that was really, really insightful. I sometimes look at the teaching points as I'm discussing, because sometimes often I'll see stuff included there that I didn't think of, and then I incorporate it into my reasoning. Thank you, Rafa. Thank you all.
Thanks, everyone. I'll just say that and Marcella is going to be discussing next Thursday. So if you want to thank her for this incredible case, please bring your own to present to her on Thursday. I can't wait to hear your wisdom, Marcella. Take care, everyone. Bring her a really hard case, okay?